Good evening to all the delegates and our eminent speaker. Thank you all for joining this evening. I am Siddhant Sharma on behalf of Hetero Healthcare. Welcome you all for the webinar on the introduction to bempedoic acid, non-statin lipid lowering agent in the management of uncontrolled LDLC. As you know, lifestyle diseases in our country is on rise and it's surprisingly moving towards a chronic stage. We at Hetero Healthcare has always been at forefront along with your side to deal with such ailment. This evening, our esteemed and experienced doctor will share their experience on the subject. Before proceeding further, let me take privilege to introduce our eminent panelist. Dr. Pavan Roy is presently an interventional cardiologist and a director of Cath Lab at Spandan Multi-Speciality Hospital, Vadodara. He is attached with the Sterling Hospital and other multi-speciality hospitals in Vadodara. He has performed more than 7,000 radical CAGs, more than 3,000 radical PTCAs, device closure and pacemaker, has presented many cases in India Live in the year 2019 and 2 case presentation at ESC Congress 2020. He has participated in many national and international level of conferences. Also glad to introduce our second panelist, Dr. Nirav Shah. A warm welcome to you on the scientific talk. He is practicing as a consultant physician at Sanjeevani Hospital, Elora Park, as well as a Lady of Pillar Hospital, Fatehganj since 1996. He is a member of IMA, API, APG, APV, and RSSDI. He is having a special field of interest in diabetology, thyroid disorders, as well as in cardiology. He has also delivered many talks on numerous topics in both state as well as in national levels. So I welcome Dr. Pavan Roy and invite him to take over the session.
Good evening, gentlemen. I would like to share my screen. So today's topic is how to tackle dyslipidemia, and it's discussing about its role in the major impact in the severe cardiovascular mortality and morbidity. And there is the huge burden of dyslipidemia, especially hypertriglyceridemia and hyper LDL cholesterol, who are having high risk factors, sedentary lifestyle, and high prevalence of diabetes and blood pressure, with a predominant of affection in the urban population, up to 25 to 30% of patients of population, and up to 50% of population in the rural population, leading to have a desirable cholesterol level to maintain CVD risk factor within acceptable limits. So definitely there is a major landmark trial called Jupiter trial, which was prematurely stopped. It was showing significant benefit in patients who are having high risk of developing ACS and ACVHD. They started on rosuvastatin, showed significant up to 40% reduction in the primary endpoint, first cardiac event or atherosclerotic event. So definitely the primary prevention of high cholesterol levels and dyslipidemia by various drugs recommended. Individuals with in middle age group, especially 30 to 40, high prevalence of dyslipidemia, and it is further aggravated up to when they are 60 years of age. Indian high risk of diabetes compared to the Western population. And a lot of deaths in India are accounting due to communicable diseases like hypertension, diabetes, cardiovascular disease, and stroke. Cholesterol level, usually the total cholesterol level, healthy level should be less than 170, and non-HDL level should be less than 120. LDL level should be less than 100, and HDL level, which is a good cholesterol, should be more than 45. There are many challenges and gaps in the cholesterol management in the current practice. So uncontrolled LDL levels, as recommended by the European Society, LDL level plays a key role in the development of atherosclerotic plaques, which lead to cardiovascular events. So many patients with this disease remain above recommended levels of LDL, is more than 100. And even though they are on maximal tolerated statin therapy, like hydrostatin therapy, they require further reduction in the LDL level by either editing ezetimibe or other drugs, which have high risk of developing CVD. So high cholesterol level leads to fatty deposition and leads to atherosclerotic cleft in the coronary arteries and other blood vessels of the body. There are various molecules to tackle dyslipidemia. The most common are statins, which include rosuvastatin, atorvastatin, and simvastatin. They reduce LDL cholesterol synthesis from the liver, HMG-CoA reductase inhibitors. There are other various drugs like cholesterol absorption inhibitors like ezetimibe, which limit the absorption of dietary cholesterol. Then bempedoic acid is a newly recently introduced molecule in the market, which further reduces the cholesterol. There are bilateral resins like cholestyramine, cholestyramine, and cholestyramine, which reduce LDL. There are PCSK9 inhibitors, which are have high cost, but there's significant reduction in LDL after introducing maximal tolerated statin therapy, which include everolimus, and they help the liver absorb more LDL cholesterol from the blood, for thereby reducing the intravascular level of LDL. Then there are phenofibrates, enzyme fibrosol, which reduce the level of VLDL and triglyceride in the blood. Niacin also helps limit the liver's ability to produce LDL and VLDL. And then there are omega-3 fatty acid supplementation, which can help reduce our triglyceride levels. Of this, we are focusing on the recently introduced molecule bempedoic acid. As per recent survey, up to 80% of treated patients on statin therapy have a suboptimal LDL level, which is less than 50% reduction in the baseline LDL level. Aggressive LDL reduction and lack of increasing statin therapy of one poor tolerance to the statin therapy is widely spread. And therefore, these patients should be addressed like having myopathy or this muscle symptoms, body ache and muscle ache. This should be this restrict the loss of increasing the statin dose to the maximal tolerated therapy. And thereby many patients, they don't adhere to the recommended therapy or stop the statin therapy completely. So residual risk, statin reduces the CV risk by up to 37%. And in residual patients, ACV risk up to 60% to 80% still persists despite optimal statin therapy. So up to 37%, they don't achieve the recommended LDL target reduction up to 50% from the baseline, or according to Indian guidance, less than 55 milligram of per deciliter of LDL, or according to American or European guideline, less than 70 milligram per deciliter. Only 20% of patients achieve this level of on statin therapy. So there are many patients who are non-adherent to their statin therapy or non-tolerant. So these patients, they should be given additional cholesterol lowering agents like ezetimibe and bempedoic acid to further reduce the CV events. There are many statin challenges like muscle weakness, myopathy, rhabdomyolysis, statin intolerance. Hence, there are some new additions should be recommended in which we can further reduce the risk of ASCVD. The reversibly SI-CoA synthesis 1 by liver and kidney to bempedoic CoA is the active form of the molecule. So it then attaches with the HMG CoA enzyme. Uh, it is then to mevalonic acid and then to cholesterol. So as active which then is a substrate for the HMG CoA or synthesis of cholesterol. So by this mechanism, this molecule acts to reduce the level of LDL. Bempedoic acid is a prodrug which is converted to bempedoyl CoA, which is leads to the SI CoA acetyl-CoA, which is a precursor for HMG-CoA reductase inhibitor, and thereby reduces the LDL. So it reduces the blood level of LDL cholesterol. The CVL1 enzyme is expressed mainly in the brain kidney, but not in the skeletal muscles. So the activity of bempedoic is restricted to liver only. So there is no weakness or pain like which is that happening from statins. The activity of statins is in muscle is potentially contributing to the statin-associated muscle symptoms, myopathy and muscle ache, which result in the poor treatment adherence and low to moderate intensity use of statin. However, it is not seen with bempedoic acid. It is recommended by US FDA as monotherapy, which was first approved in February of 2020, and then in combination with ezetimibe, case later on FDA approved, especially in patients with heterozygous familial hypercholesterolemia or established ASCVD. Patient with significant dyslipidemia, it is helpful to reduce the levels of ApoB and non-HDL and LDL cholesterol compared to placebo. And there is significant reduction in HSCRP levels also, which reduce inflammation in the body. So in diabetic patients, there is a 43% reduction in LDL, 41% reduction in HSCRP levels. So in both diabetic, dyslipidemia, and hypertensive patients, we can see up to 21% reduction in LDL cholesterol levels by 6 weeks, and 25% reduction in the patients who were treated with bempedoic acid. In combination with statins, they help to reduce LDL cholesterol by 22%, and this is a safe and effective add-on drug with statins. Indications: those having familial hypercholesterolemia who are on maximally tolerated statin therapy, or patients with heterozygous or familial hypercholesterolemia, established ACV like ACS patients, stroke patients who require additional LDL lowering therapies. We can give this drug with a 180 milligram once daily regimen. There is some drug interaction with simvastatin and pravastatin, but which are not used regularly nowadays compared to atorvastatin and rosuvastatin. Specific population like pregnant patients, lactating and pediatric population, it is not recommended. Adverse reaction: most hyperuricemia, back pain, abdominal pain, some bronchitis, pain in extremity, anemia, and elevated liver enzymes. But these are less than 2%. Hyperuricemic patients like with elevated uric acid, some elevation can be found in this patient. So regular monitoring of uric acid levels should be taken. There are multiple clinical trials like Clear Serenity, Clear Wisdom, Clear Harmony, Clear Tranquility trial, and bempedoic acid in hypercholesterolemia and diabetic patients. So all these trials, they were taken in intolerant patients. So in the summary, with all these trials, with more than around 3,500 patients. So clearly, with all these trials done, we can summarize that this molecule bempedoic acid leads to further reduction in the LDL levels, thereby reducing the future MACE events, ASCVD risk, and CV deaths, without much increase in the adverse events like myopathy and muscle aches, especially in statin intolerant patients. So key point, as you can see in CKD patients, there is no dose adjustment needed. In hepatic chronic liver disease patients also no dose adjustment needed. However, we have to monitor these uric acid levels in patients with gout or hyperuricemia, and in elderly patients who are taking steroids or fluoroquinolones or renal failure or history of tendon rupture. There may be some adverse events and tendinitis can occur in some patients. So in patients who are on older statin drugs like simvastatin or pravastatin, concomitant use can be considered if we reduce the dose of statin or we switch over to atorvastatin or rosuvastatin. and it is not recommended in breastfeeding and pregnant patients. So in other trials also like bempedoic acid in hypercholesterolemia, it was a pooled analysis with phase 3 randomized clinical trials. It was studied for 52 weeks, and primary endpoint was reduction in the LDL level. It showed there was a 16% reduction of LDL with bempedoic acid compared to placebo with less than 2% in placebo group. So this reduction was sustained even in long-term follow-up also, which led to further reduction in the ASCVD or heart failure patients. So in patient with hypercholesterolemia, we can definitely recommend this drug. Diabetic, pre-diabetic patients also, as you can see, up to 1 year, it did not worsen any glycemic variables, and there was no increase in the incidence of new onset diabetes. So it is safe in diabetic population also. So in conclusion, we can see it is a novel molecule which acts as in a different pathway. It is recommended in patients who are not tolerating statins or not on maximal statin therapy. We can further reduce the inflammation in HSCRP and ApoB by this molecule. It is safe as it doesn't have significant adverse effects like myalgia and with minimal drug-to-drug interaction. Thank you. I would like to have any questions if.
Dr. Nirav sir would like to
Yes.
also contribute in terms of this perspective. Dr. Nirav sir.
Uh, Definitely, it is quite challenging to treat patients either with established atherosclerotic cardiovascular disease or patients who are at high risk of cardiovascular disease. The challenge of treating the LDL levels and bringing them to the target levels is actually better understood, but I would say quite under practiced. Many patients are on suboptimal doses of statins. However, when one tries to bring the LDL levels to target levels, it happens so that the patients are unable to tolerate the higher dose of statins because of the adverse effects like myopathy. Sometimes some patients may have elevations of transaminase, though this adverse effect is quite uncommon. Such patients, till now, the option was to maybe to try another statin or maybe to add ezetimibe and to intensify the lifestyle modification measures and see whether the LDL comes to the target level. Combination with ezetimibe and statin has been now again viewed with increased interest nowadays. Earlier it was used, but for few years in between it had gone out of vogue. However, even with use of ezetimibe, it has been observed that many patients may not achieve the target LDL level. So in such patients, adding bempedoic acid is definitely a good option. And the studies till now have shown that adding bempedoic acid reduces LDL further by almost 22%. LDL goes down further by 22%. So bempedoic acid, though, has been used in trials as monotherapy, but its main role, I think, would be as an addition to maximally tolerated statin dose, or in patients with statin and ezetimibe who still are not at target LDL.
Thank you so much, sir. Any closing remark, Dr. Pavan and Dr. Nirav Shah?
Yeah, basically, bempedoic acid as a molecule is a novel molecule of its class, the only of its class. It has a simple mechanism of action, and basically it holds quite a lot of promise in managing patients with both familial hypercholesterolemia as well as patients with high risk AS CVD who are like not able to achieve the target levels. Bempedoic acid definitely holds promise, and only time will tell like its importance in treatment.
Dr. Pavan?
Yes, definitely. As in our practice cardiology, post PCI patients, every patient should be on high dose statin therapy, as they already have established ASCVD, already have ACS or MI or unstable angina or stable angina. So definitely many patients we start usually with the 20 or 40 milligram of rosuvastatin or atorvastatin, but then we cannot achieve the maximal dose. Like in many, I've seen patients who are elderly female, especially 40-50 kgs. They don't achieve even half dose of the statin. So we have to add additional LDL lowering agents like bempedoic acid and ezetimibe in these patients. Even after maximal storage, even in many young patients who are obese, having advanced atherosclerotic diseases, even after giving rosuvastatin 40 milligram, also their LDL level is more than 100. So we have to add additional therapies, which include these drugs and ezetimibe. So in many patients in our practice, uh, we have indications of giving this molecule.
Thank you, Dr. Pavan. Moving to the Q&A session, we have questions in the chat box. I think any both of you can contribute to those questions coming from the doctors.
So I would like to start with the few questions, like scope of bempedoic acid in cardiac clinical practice. No doubt we have to first start with the statin therapy, but according to guidelines, we have to recheck the LDL levels and lipid profile after 3 months of uh, starting or post-plastic patients. If the LDL reduction is not more than 50% reduced from the baseline, or target LDL is not less than 70, then either we have to increase the statin dose and then, or we have to add additional drugs. So treatment protocol is all according to baseline LDL levels. Many patients, they have a baseline LDL of around 80 or 90, but still we have to give high dose of statin therapy if the patient develop ACS or atherosclerotic diseases. So for that, target LDL is less than 40 compared to baseline LDL 30. So the patient's LDL levels, they differ on the different patients. It's not fixed, but still there is a baseline of target of 70. So in all patients, at least less than 70 LDL should be targeted in established ASCVD patients. Compared with other drug, we can directly start with bempedoic acid if they have uncontrolled LDL. So definitely we can start with high dose statin therapy, and even patients who are having family history, strong family history, or LDL more than 200, 250, 300, familial hypercholesterolemia. In that patients, you can also directly start the bempedoic acid with statin therapy. And uric acid should be monitored, especially who are known patients having or who are already on uric acid lowering therapy like febuxostate or aripiprazole. So uric acid levels should be monitored every 2 weekly or 4 weekly. If the uric acid remains stable, then we can continue bempedoic acid also. So lipid profile after bempedoic acid, according to guidelines, 4 to 6 weeks intervals, it is recommended after starting LDL lowering therapy. And a recent 2019 ACC-AHA guidelines are available online. So we can follow that guidelines. And any demographic like age or comorbidity, as you can see that I've seen many elderly female patients, like more than 60, 65 years, thin patients who don't have any muscle mass. So in this patient, there is high chances of statin-induced myopathies or muscle aches. So in such patients, we can add bempedoic acid as an additional drug.
Thank you, Dr. Pavan. Dr. Nirav, any post complications in lipid profile?
Post-COVID complications. There were some patients who did develop stroke and myocardial infarction early in the in the initial maybe 1 to 1.5 year after the onset of the COVID pandemic rather. So I am not sure whether there was any systematic study of such patients related to their lipid profile. Of course, COVID infection and in the post-COVID state, there were many reasons for such patients developing a prothrombotic state and developing complications like a coronary event or a stroke. So, lipid profile, the correlation of a change in lipid profile compared to the pre-COVID time in such patients, I am not aware of any data available. For how much time patient can be given bempedoic acid is one question. I think bempedoic acid, when added to either statin or statin with ezetimibe, which is already going on, can be continued if there are no indications to withdraw it because of any increase in serum uric acid level or any intolerance, and can be given for a prolonged period of time provided the LDL target is also achieved. I think other questions Dr. Pavan has very well answered.
I think, yeah, I think we have covered all the questions, Doctor. And yes, thank you very much for joining. It was indeed a pleasure and honor having you doing this webinar. We, on the behalf of Hetero Healthcare, would like to extend our sincere thanks to you for your comprehensive session. And we are sure our delegates would have got enlightened regarding this molecule, as we have covered all the possible aspects in your session. Also, we would like to extend our thanks to all the participants or doctors who have joined for this session. Thank you so much. Thank you very much, Doctor, for joining. Nice.
Thank you.